Bladder tumors are most common tumors in the urinary system, mostly originating from epithelial tissues. More than 90% bladder tumors are transitional epithelial tumors. Etiology: long-time exposure to industrial chemicals, smoking, chronic infection of bladder, and long-time stimulation by foreign matters. Oncogene activation, deletion of tumor suppressor gene, and genomic mutation. Pathology: it is related to the tissue type of tumor, the degree of cellular differentiation, the way of growth, and the invasion depth, among which the cellular differentiation and the invasion depth are the most important factors. As for the tissue type, more than 95% bladder tumors are epithelial tumors, among which most tumors are transitional cell carcinomas and squamous carcinoma, and adenocarcinoma account for 2 to 3%. As for the differentiation degree, bladder tumors can be divided into 3 grades according to the size, morphology, staining, nuclear change, and division of tumor cells. Grade 1 shows good differentiation and low malignancy. Grade 3 shows poor differentiation and high malignancy. Grade 2 is in between grade 1 and grade 3 with moderate malignancy. As for growth patterns, they are divided into carcinoma in situ, papillary carcinoma, and invasive carcinoma. The carcinoma in situ is confined in the mucosa without papilla and invasion. The transitional cell carcinoma is most papillary. Squamous carcinoma and adenocarcinoma often showed invasion, and different growth patterns may exist alone or simultaneously. The invasion depth is the basis of clinical and pathological staging of tumors, which can be divided into TIS carcinoma in situ, TA papillary no invasion, T1 confined to lamina propria, T2 invading muscles, T3 bladder wall penetrated, T4 invading adjacent tissues of prostate or bladder. The tumors at TIX, TA, and T1 stages are called non-muscle invasive bladder cancer. The tumors at T2 and above are called muscle invasive bladder cancer. Metastasis: the spread of the tumor mainly refers to the invasion into the deep part, even into the extravesical tissues. Lymphatic metastasis is most common, and hematogenous metastasis often occurs in the late stage. Clinical manifestations: the age of high incidence of bladder tumor ranges from 50 to 70. Male, female at 4:1 ratio. Superficial papillary tumors are the most common. Poorly differentiated invasive bladder cancer often occurs in elderly patients. Distribution: mostly distributed in side and rear walls, followed by trigone and top. Hematuria: most patients sought medical treatment due to gross painless hematuria. The general manifestation is intermittent painless total gross hematuria. The amount of blood is not consistent with the size, number, and the malignancy of the tumor. Urinary irritation symptoms: dysuria, urine retention, and lower abdominal mass. In the late stage of bladder cancer, such symptoms as invasive masses of lower abdomen, severe anemia, and edema can be found. Squamous carcinoma and adenocarcinoma are highly malignant with a short course of disease. Squamous carcinoma can be caused by long-time stimulation of stone. Diagnosis: gross painless hematuria. The possibility of urinary tumor shall be considered if any adult especially over 40 years old, has developed painless hematuria, especially bladder tumors. Hematuria is easily misdiagnosed as cystitis when it is accompanied by bladder irritation symptom and urodynia. In case of cystitis, bladder irritation symptoms are often more serious with sudden onset. Hematuria appears after bladder irritation symptoms. Examination of exfoliated cell. It is easy to find exfoliated tumor cells in the urine of patients with bladder tumor. The method is simple and can be used as a preliminary screening for patients with hematuria. Cystoscopy. The tumor site, size, number, morphology, pedicle condition, and basal invasion degree can be directly seen. The carcinoma in situ shows no other abnormalities except localized redness of the mucosa. The superficial papillary carcinoma, that's Ta-T1, is light red, like floating water grass. The invasive papillary carcinoma, T2-T3, is dark red and relatively solid, with papillary fusion, partial mass, edema of mucosa around the pedicle, and light activity of marks in water. The invasive carcinoma T3 and T4 shows brownish miles. The ulcer is formed due to surface necrosis. The margin bulges and forms edema, and carcinosis may occur. X-ray examination. Excretory urography can be used to learn about the presence or absence of tumor in the renal pelvis and ureter, as well as the effect of tumor on renal functions. Hydronephrosis or poor development under urography often suggests that the tumor invades the ureter. The filling defect can be found during cystography, and the wall of the bladder is stiff and irregular. Ultrasound examination. A bladder tumor above 0.5 cm can be found. CT and MRI examination. The invasion depth of the tumor and the local metastasis of lesion focus can be found by CT and MRI. By manual examination of bladder, the size of bladder tumor, invasion extent, depth and relationship with pelvic wall can be examined. Treatment principles. Surgical treatment is mainly adopted. The most appropriate surgical method should be selected according to the pathology of the tumor and the systematic conditions of the patient. Treatment of non-muscle invasive bladder cancer, that is TIS, TA, and T1. The transurethral resection of bladder tumor is not only an important diagnostic method for bladder cancer, but also a main treatment method. Resection of all visible tumors, pathological grading and staging of the resected tissues for facilitating the determination of the next treatment program, infusion of chemotherapy drugs within 24 hours after surgery, infusion of immune agent 2 weeks after surgery. Surgical treatment. Cavity surgeries, transurethral resection of bladder tumor, laparoscopic partial cectomy, laparoscopic total cectomy. Open surgery, cystotomy for excision of bladder tumor, partial cystectomy, total cystectomy, etc. Follow-up of bladder sparing surgery. The bladder tumor is easy to reoccur after resection, but it is still possible to cure after recurrence. After the bladder sparing surgery, any patient shall be closely followed up, examined with cystoscopy after 3 months, and re-examined every 6 months in case of no reoccurrence in 2 years. Prevention. There is no effective preventive measure for bladder tumor at present, but labor protection should be enhanced for the professionals in close contact with carcinogenic substances and the smokers should quit smoking as early as possible, which can prevent or reduce the reoccurrence of tumor. After the bladder sparing surgery, infusion of chemotherapy drugs and BCG in the bladder can prevent or delay the reoccurrence of tumor.